Now we are going to the second part of the today's program. That is the lecture series. There are 5 talks. To lead us through these lectures, we have 2 moderators. One is Dr. Mahesh Prabhu. The other one is Dr. Sanjeevani Namdar. Both, I don't think they need any introduction. Mahesh Prabhu is leading cardiothoracic anesthesiologist from Newcastle in UK. And Sanjeevani Namdar, again, is a leading cardiothoracic anesthesiologist with a lot of interest in echocardiography from Pune. And they will lead us through the presentations. And please note that all the questions will be answered at the end of the session. Please put your comments and questions on chat box. Moderators, I request them to introduce the speaker and the topic in a very succinct manner and stick to the time as far as possible. And panelists, I request them to join at the discussion at the end of the session. Please feel free to contribute to the discussion at the end of the talks. And speakers are requested to stick to the time limit of 18 minutes. Please do stick to this so that we will finish in time and be able to have your dinner in the right time. With these few words, I will invite Dr. Mahesh Prabhu and Sanjeevani Namdar to take over the proceedings. Thank you once again.
Hello everyone. Good evening. After listening to these young scientists, let us start now speeches by eminent speakers in this field. But before that, I would like to invite the team of our panelists, very eminent panelists. So I would invite first Dr. Yadav, who is from Delhi, a heart surgeon. Good evening, sir. Then Dr. Uday Gandhe. He is a renowned cardiothoracic anesthesiologist from Mumbai. Then Dr. Unni Krishnan from Sri Chitra Trivandrum. Then I invite Dr. Shiman Narayan from Narayana, Bangalore. And I invite Dr. Rahul Guha Bishwas from Kolkata. I don't see them. Where are they? Yes, Rahul. Yes.
Hi, how are you?
Hello. And what about Dr. Mahesh? Please put on your video.
Can you hear me? For some reason, I can't get my video working. It says you cannot start your video because the host has stopped it.
Okay. Kiran, please take care of that. Okay,
I think, Kanchan, you sort out this issue. Dr. Shivam, please switch off your video.
There we go.
Yeah, okay.
See, delegates, you know that the real romance in cardiology is in hemodynamics. It's difficult, it's fascinating, and it is brain teaser too. And in addition to that, one has to give 100% attention to get good results. I think many people, I can't see them, but I'm sure young people in this crowd must be laughing for this. And to start this interesting and tough topic today, I would like to invite none other than my dear friend, Dr. Debika Chhatterjee. Debika, please switch on your mic as well as video. Dr. Debika doesn't need any introduction. She is not new to this community, and it's our proud privilege to have her here. And if I can see her biodata on her slide, you can see how much she has achieved. She is Chief of Non-Invasive in Narayan Hrudayalaya in Kolkata, Executive Committee member of Indian Academy of Echo, and actively involved. And she has been my teacher and my colleague too, as a moderator or teaching Echo to youngsters. Welcome, Dr. Debika. Please start.
Thank you, Dr. Sanjeevani, for the kind introduction. Hello, everyone. I'm going to speak on hemodynamic calculations by echocardiography. As Dr. Sanjeevani has said, hemodynamic calculations involve a lot of mathematical equations, which many people are scared of. But fortunately, these mathematical equations are greatly simplified for the use in echocardiography. So these hemodynamic calculations can be made within a minute while doing echo at the bedside, leading to better diagnosis and better clinical management of the patients, because these calculations help us in making diagnosis, in making line of management, in making a decision regarding line of management. They guide us in the interventions and also help in follow-up. So the knowledge of these calculations definitely push forward the role of intensivist, anesthetist, and the cardiologists in managing the medical and surgical patients. In the earlier days, signs of hemodynamic abnormalities were obtained by MOD and 2D echo findings, but these are very non-specific and indirect evidences. With the development of Doppler echo, now we have more direct and quantitative technique to estimate to get various hemodynamic calculations like stroke volume and the cardiac output, pressure gradient at the site of obstruction, valve area, intracardiac pressures, LV filling pressure, pulmonary arterial pressures, and as well as regurgitant volume. So let us go one by one. Let us start with stroke volume and cardiac output. As you know, cardiac output is a very important hemodynamic parameter in critically ill patients, because these critically ill patients who have the low cardiac output in spite of aggressive therapy have very high mortality rate. And some of these patients respond very well to the fluid replacement therapy. So we must know the cardiac output of all critically ill patients. As all of you know, the stroke volume is the amount of the blood pumped out per beat, and cardiac output is the amount of the blood pumped out per minute. So cardiac output is equivalent to stroke volume into heart rate, and cardiac index is cardiac output divided by body surface area. So all we have to know is stroke volume, which is nothing but a flow across the cardiac orifice, and it is calculated from a formula called...
Debika, the slides are not moving. Can you please check?
Slides are not moving, really?
I have not seen any slide moving.
Me too.
Yes, they are not moving.
Have you changed the slides?
No, yes, I'm changing it. Stroke volume, cardiac output.
It's not seen here. It's not.
It's not seen?
Only the short CV is seen.
I think you unshare your screen and share it again, please.
Okay. Can you see it now?
Yes.
Yeah. Now we can see.
You can see now? Okay.
Yes.
Okay. So, so let us see how we calculate the stroke volume, which is a flow across orifice derived from cross-sectional area multiplied by flow velocity. The formula for cross-sectional area is pi r square. We don't measure the radius. We can't, because the orifice of the heart is not circular, though it is assumed to be. We determine the diameter, and so it turns out to be d squared. If we derive the formula, it turns out to be d squared into 0.785. And regarding the flow velocity, instead of measuring the peak velocity, we measure the VTI, because heart is a pulsatile structure and the flow is not constant. So the equation now is stroke volume is equal to d squared into 0.785 into VTI. And this can be measured at any orifice of the heart, provided there is no regurgitation and no intracardiac shunt. However, it's most reliable to measure at aortic valve, because it's very easy to measure the aortic LVOT diameter, and the flow at LVOT is laminar. So we measure the stroke volume just in 2 steps. In step 1, we measure the LVOT diameter, and in step 2, we measure the LVOT VTI. This is the way we measure the LVOT diameter. In transthoracic echo, it's the parasternal long axis. In transesophageal, it's the mid-esophageal aortic valve long axis. But we have to be very careful while measuring the diameter, because any error will be squared. So we need to take certain technical precautions while measuring the LVOT diameter, like we should always measure it in zoomed view. It is in mid-systole, and always measure within 5 to 10 millimeter from the aortic annulus as per the AEC guidelines, the latest AEC guidelines. So that is the way we measure the LVOT diameter. And for LVOT VTI in transesophageal echo, we go to the either mid-transgastric view at 120 degree or deep transgastric view at 0 degree fully flexed. So, and we keep the sample volume in the LVOT, this is the aortic valve, and get the pulse wave Doppler, and we trace it to get the VTI of the LVOT. The machine calculates and gives us the value of stroke volume and cardiac output. The next very important clinically significant hemodynamic calculation is to get a transvalvular gradient by using modified Bernoulli equation, which says pressure gradient is equal to 4 multiplied by V square, where V stands for the velocity of the blood across that particular valve. And this pressure gradient, which we derive from this formula, quantifies the degree of valvular stenosis. Let us take the example of a case who is 65 years old, male, presented with chest pain, SOB, repeated syncope, systolic murmur, and the LVH. In the transthoracic, we see densely calcified aortic valve, hardly any opening. Color flow shows turbulence in transthoracic as well as in transesophageal echo. Now, to see the gradient, we all of us we know that the pressure gradient is most accurate when the flow is parallel to the cursor. In transthoracic, we have many views, but in transesophageal, we always have to go to the transgastric view. This is a mid-transgastric at 120 degree. My flow across the aortic valve is absolutely parallel to the cursor, and I get a peak velocity of 4.74 meter per second. Machine gives the value of peak gradient of 90 millimeter of mercury. Now, if you see that I have traced this spectrum, this is to get the mean gradient across the aortic valve, because the studies have shown that mean gradient obtained by color Doppler corresponds very well with the pressure gradient obtained by cardiac catheterization. Moreover, as per the latest AEC guideline, the grading of aortic valve stenosis severity is done according to the mean gradient, not the peak gradient. However, there is a fallacy in it. Look at this patient. This patient, again, if you look at the valve, it's severely stenosed, calcified valve. But when I see the gradient, this is a transthoracic views in the apical 5 chamber, I get a mean gradient of 27 millimeter of mercury. Though this is a case of severe aortic stenosis, if I go by the mean gradient, this falls in the moderate aortic stenosis range. But if you look at the valve, it's deep, it's hardly stenosed, and it's densely calcified. Basically, we are facing a situation of low flow, low pressure gradient, severe AS in this patient with the reduced LV ejection fraction. You look at the LV ejection fraction is hardly 35 to 40%. These LV cannot generate a significant pressure gradient, though there is a severe aortic stenosis. So in this particular group of patients, severity of the AS cannot be determined by looking at mean gradient. We calculate the severity by measuring the aortic valve using another very important hemodynamic equation called continuity equation, which follows the principle of what goes in must come out. So what does it mean? It means stroke volume at LVOT is equal to stroke volume at aortic valve. We have already learned how to calculate the stroke volume at LVOT, and the formula for stroke volume at aortic valve is aortic valve area into aortic valve VTI. So the whole thing gets divided by aortic valve VTI, and we measure the aortic valve area by continuity equation in just 3 steps. First 2 steps are same as we do for a measurement of stroke volume. And in step 3, we measure aortic valve VTI by CW Doppler. So this is step 1, LVOT diameter, step 2, LVOT VTI from the pulse wave Doppler at LVOT, and step 3 is the aortic valve VTI from the CW Doppler across aortic valve. The machine gives the value of aortic valve area of 0.45 square centimeter. Now, using this modified Bernoulli equation, it's possible to see the pressure gradient in mitral stenosis also, putting the CW Doppler across the mitral valve, and we trace it because it is the mean gradient which is relevant. The peak gradient is of little interest. So here is the mean gradient. Machine will calculate and give the values. Now we must remember that there are certain factors which influence the pressure gradient in mitral stenosis. A very important factor is the heart rate. If there is a tachycardia, there will be erroneously high gradient across the mitral valve. And so pressure gradient alone is not an ideal indicator of severity of mitral stenosis. So we have to calculate mitral valve area by one more hemodynamic calculation. It's called pressure half time. It is the time which it is less dependent on the heart rate, and the pressure half time is the time needed for pressure gradient to decline to half of its value from the peak. The formula for mitral valve area is 220 divided by pressure half time, and we calculate the valve area from the mid-esophageal 4-chamber view, doing CW Doppler, fix one point at the peak of E, the second point at the minimum velocity, and the machine calculates the value of mitral valve area from pressure half time. Now, pressure half time is inversely proportional to the valve area. Larger the mitral valve area, shorter is the pressure half time. Now, using again the modified Bernoulli equation, we can get a gradient across the VSD. Here you see there is a perimembranous VSD, very small, with this is left ventricle, right ventricle. There is a left to right flow. I place the cursor, get the CW Doppler, and machine gives a gradient of 88 millimeter of mercury. Now, once I get this gradient across the VSD, it's easy to estimate the RV systolic pressure, because basically this gradient means the pressure difference between LV and RV. So RV systolic pressure will be LV systolic pressure minus the pressure gradient across the VSD. So it turns out to be 32 millimeter of mercury, and this reflects the pulmonary arterial systolic pressure, provided there is no RVOT obstruction. Let us move to another very important hemodynamic equation, that is the estimation of LV filling pressure. Let us take the example of this case, 60 years old male, presented with dyspnea, ankle edema, all the findings of congestive heart failure. Now, to find out the cause, we do the echocardiography, and we see that there is no systolic dysfunction. LV is showing very good ejection fraction. Then what is the cause of congestive heart failure? It's not a systolic failure. So we do the Doppler echo, and what we see that there is an advanced diastolic dysfunction with elevated LV filling pressure. So basically, we are facing a situation of HEPF, or diastolic heart failure with preserved ejection fraction, where elevated LV filling pressure is a marker of poor prognosis. So, and this LV filling pressure can be easily measured by in echo from a parameter called E by E prime, which is a ratio of transmitral E velocity to the mitral annular E prime velocity. First, we do the pulse wave at mitral at the level, keeping the sample volume at the level of the tip of the mitral valve leaflets, take the E wave velocity, switch on the TDI mode, go to the septal annulus of the mitral valve, and do the tissue Doppler, pulse wave Doppler. The first E prime velocity is taken, and ratio is ratio of E by E prime at septal annulus, and then again in the lateral annulus, we take the average, and average E by E prime more than or equal to 14 predicts raised LV filling pressure. Now, in my patient, the LV, this average E by E prime was 20.12. So that is why he was in frank heart failure. This is the way we do the tissue Doppler imaging. This is transthoracic echo. Same way we can do in the transesophageal also. First, flow pulse wave Doppler of the mitral valve, then tissue Doppler of these annulus of the mitral valve. Now, let us go to the right heart hemodynamics. Do I have time? Right heart catheterization is the gold standard, but Doppler echo is another alternative, very useful to estimate systolic, diastolic, and mean arterial pressure, and also to estimate the severity. Here we use the TR jet. As you can see, there is a small TR, and we put the cursor to get the TR gradient of 45 millimeter of mercury. And this indicates the pressure difference between RA and RV. And if we add RA pressure, that will give the RV systolic pressure, and that RV systolic pressure will reflect the pulmonary arterial systolic pressure, provided there is no PS or RVOT obstruction. Now, let us see how we measure the RA pressure. That we do by looking at the IVC from the subcostal view. I look at the diameter and its collapsibility in inspiration with sniff. We measure at 1 to 2 centimeter from the junction with RA, and then we follow the guidelines of AEC. If the diameter is less than 2.1 centimeter and collapses more than 50%, then the RA pressure is 3. And if the diameter is more than 2.1 centimeter and collapses less than 50%, the RA pressure is 15. So this is the way we get the pulmonary arterial systolic pressure. For pulmonary arterial diastolic pressure, we go to the parasternal short axis view in transthoracic to get the PR jet, and we take the end diastolic PR jet gradient plus RA pressure to get the diastolic pulmonary arterial pressure. And to get the mean pulmonary arterial pressure, in the same PR jet, instead of end diastolic, we take the peak diastolic gradient and we add the RA pressure with it. And we also can get mean pulmonary arterial from pulmonary valve acceleration time. For that, we keep the sample volume at the level of pulmonary valve in parasternal short axis, get the RVOT flow, and this is the RVOT flow, and we measure the acceleration time. Normally, it's more than 130 millisecond, and if it is less than 100 millisecond, it indicates pH. And with using this acceleration time in some equations, one of those called Mahan's equation, we can estimate the mean pulmonary arterial pressure. Another, my last, in fact, hemodynamic calculation is the measurement of ERO and regurgitant volume of mitral regurgitation by PISA. PISA means the proximal isovelocity surface area. As you know, the regurgitant blood, as it moves from LV to LA, it forms multiple hemispheres. Somehow we'll have to find out the closest proximal hemisphere because the flow at that PISA is same as the flow of the regurgitant orifice. So there is the formula, and it's just done in 2 steps. In step 1, we get the CW Doppler. We trace it to get the peak velocity and the mean VTI, and then we reduce the aliasing velocity in step 2 to minus 30 to minus 40 in the direction of the MR jet to get this proximal isovelocity surface area, which is identified by the interface of yellow and blue, and we measure the radius. The machine puts the values to get the effective regurgitant orifice area. This is the aliasing velocity. Peak MR velocity we have already measured, and regurgitant volume is the ERO into VTI, which we have already measured. In severe MR, ERO is more than or equal to 0.40 square centimeter, and regurgitant volume is more than 60 ml. It can easily be measured. This we can do in transesophageal echo also in the same way. So to conclude, my friends, you have seen that there is an unquestionable role of all these hemodynamic calculations by echocardiography, and so it should be practiced by all intensivists, anesthetists, and cardiologists while doing echocardiography in pursuit of excellence in diagnosis and treatment. Thank you.